So yes, imaging is continuously evolving in myeloma, but what we discussed was that finally we reached some firm point. So the first one is the minimum requirement for the diagnosis staging of myeloma patient, that is whole body low-dose CT, very friendly of use, cost-effective, available everywhere, so that's the minimum. Then we discuss about the additional role of PET-CT and diffusion-weighted MRI that are also adding a prognostic evaluation of the patient. So in the countries where this is affordable, no reimbursement issue, where there is the expertise, you can use these techniques instead of whole body low-dose CT for the staging. Because the new diagnostic criteria are admitting also these techniques to be used to demonstrate active myeloma bone disease. The other good news is that the three techniques, so whole body low-dose CT, MRI, and PET-CT, are standardized nowadays, so they can be used all over the world, obtaining more or less the same results. The second part of my talk was focused on the evaluation of response to therapy. Nowadays we know that to evaluate residual disease we should look also outside the bone marrow, so with imaging techniques. The established technique is PET-CT. All the guidelines and recommendations are mentioning PET-CT. However, there is an emerging role of diffusion-weighted MRI with initial data from the UK group, from other groups. So in the near future, for sure, we will have two established techniques to evaluate response. So according to the availability in different centers, you may use one of the two. And lastly, I also discussed the fact that, of course, there are new emerging minimal residual disease techniques at higher sensitivity level. For example, I'm referring to liquid biopsy, mass spectrometry, so they will challenge in the near future both bone marrow techniques and imaging. But by now, they are still remaining the standard of care. So nowadays, imaging should be used to evaluate response to therapy.